Good evening, everyone. I'm Tony Segreto, and once again, so very honored to be your moderator for tonight's In the Know Town Hall. We hope you all had a wonderful and peaceful summer and ready for a new season of In the Know. And tonight, we're discussing a topic of utmost importance, fertility, and the struggle that some couples have in conceiving. For would-be parents, infertility can be a devastating diagnosis, and it's a lot more prevalent than you think. In fact, 1 out of every 8 couples have trouble conceiving. Now, there are many factors that cause infertility, from reproductive abnormalities for men and women to genetic or hormonal conditions. There are also underlying medical conditions that may disrupt the process. Fortunately, we now know there are promising research advances and treatment options that are bringing hope to millions of people across the entire world. These advances include assisted reproductive technology to genetic screening and reproductive endocrinology and urogynecology. Now, tonight, our world-class physician scientists are here to discuss those latest technologies, the innovations in treatment options, and the promising research in the field of fertility. Now, we have, and I'm going to underscore this a whole bunch of times tonight, an incredible panel assembled for you. These are experts from the Miller School's Department of Obstetrics, Gynecology, and Reproductive Sciences. It's led by Dr. Michael Paidas. In fact, he's going to lead the panel tonight. He's the professor and chair of the Department of Obstetrics, Gynecology, and Reproductive Sciences. He's also the chief of service at the University of Miami Hospital and Clinics and chief of service at Jackson Health System. Joining him is Dr. Pasquale Patricio. He is the chief of the Division of Reproductive Endocrinology and Infertility and the professor of Obstetrics, Gynecology, and Reproductive Sciences. Also joining the panel tonight is Dr. Stephanie Delgado. She's an associate professor in the Clinical Division of Obstetrics and Gynecology. And last, but certainly not least, is Dr. Ranjith Ramasamy. He's an associate professor of clinical urology and director of reproductive urology at the Sai Seti Urology Institute at the Miller School. See what I mean? It is truly a world-class group of experts. You know what we say here at In the Know. This panel is like the Mount Rushmore for you tonight. So it's a special group. Now, before we get started, let's go over how you can participate in tonight's conversation. After Dr. Paidas has delivered his opening remarks, the panelists will answer the questions that you've submitted over the last few days. And I have to tell you, the questions tonight that you've submitted are magnificent. I mean, they are so spot on. You're going to really enjoy hearing all these doctors weigh in on these questions. You're also going to have the opportunity to submit questions during this program. Now, for those of you who have been with us or you need kind of refresh, or those of you who are new, really simple. At the bottom of your screen, there's a Q&A feature. Use that Q&A feature to send us your questions. All the questions submitted are anonymous, and we promise we will get to as many of them as we possibly can. But in order to do that, we have to get our evening underway. So it is my pleasure now to introduce Dr. Michael Paidas. And Dr. Paidas, I know how busy you are, and to take the hour with your team out tonight to talk about this to all the people who are so interested, we are very honored to have you, sir. So thanks for being here.
Well, good evening, and thank you, Tony. I'm really delighted to be with you all tonight, and I'm equally honored to speak on behalf of our extraordinary faculty, our physicians, and staff in the Department of Obstetrics, Gynecology, and Reproductive Sciences at the Miller School. It is a distinct privilege for my colleagues and I to share our expertise, our experience, and research with you tonight. We know that about 10% of women in the United States aged 15 to 44 have difficulty getting pregnant or staying pregnant. And there are a lot of reasons why this happens. Other women need to delay attempts to conceive due to pregnancy health concerns or other reasons. We're going to look at a few of these issues tonight and provide you what's going on to offer some different solutions. What's important to note is that this is an academic medical center, and our physicians are participating in breakthrough research studies that are leading the newest diagnostic treatments and diagnostic therapies. Joining me tonight are the experts that are advancing our research and patient care that is making all the difference for those that we serve. Dr. Patricio's expertise in oncofertility will help us explore innovations in fertility preservation in youth and cancer, as well as in pregnancy loss. Dr. Delgado is an expert in treatments for endometriosis and minimally invasive surgery. And Dr. Ramasamy specializes in the diagnosis, causes, and treatment of male infertility. So our goal tonight is to answer your most pressing questions about the causes, prevention, and treatment of infertility. Tony, back to you.
Thank you, doctor, for that intro. And let's get to our first question of the evening. And Dr. Patricio, we're going to have you kick it off tonight. And the question goes like this: what is elective fertility preservation, and how would you counsel young women interested in egg freezing?
Thank you, Tony, and welcome to all the members participating in the audience. So what is elective fertility preservation is the opportunity to preserve by cryo preservation either eggs or sperm or embryos that are going to be used at some point later during the reproductive lifespan. It's called elective because it's important to contradistinct from medical fertility preservation, which are technology used mostly for women or men, that they are affected by medical condition, either cancer or any other medical condition that may impair and jeopardize the health of the ovarian activity or testicular tissue. So elective fertility preservation is done as a mean to postpone fertility when the time is right. Now, how we counsel women towards this technology? It's very important to have a thorough consultation where we go through the pros and the cons in approaching this type of technology. In fact, it requires important description on how it's done, the medications that need to be used, the time that is required, but also the pros and the cons on what is the most ideal time to do it, and what are the costs that are involved with these procedures, and what is currently the utilization rate of such technique. And then the $1 million question that is, okay, doctor, I definitely want to do it. How many eggs should I freeze? And this probably will come up later in the discussion because it's a very important question.
Thank you, doctor, so much. All right, so now our next question is, I think, Doctor, let me see what we have here, Dr. Delgado. What is endometriosis and how do I know if I have it? Welcome, Dr. Delgado. It's nice to see you.
Nice to see you. Thank you so much. So like Dr. Peta said, I specialize in endometriosis. And so endometriosis is really a condition that affects about 10% of women. And it's mostly comes up with pelvic pain and really heavy periods. And so what it is essentially the endometrial cells that are supposed to be within the uterus, in the lining of the uterus, are somewhere they're not supposed to be, somewhere ectopic. And so most of the time that ends up being either on your ovaries as cysts, and those are called endometriomas, on your fallopian tubes, which can cause adhesions and scar tissue, but it can also be in your bowel, in your bladder, and your ureters, up to your diaphragm and your lungs. And so it's something that it can be very severe and can definitely, we see it affecting pregnancy and fertility because it does affect ovarian reserve and affects the fallopian tubes as well.
Thank you, Dr. Delgado. Dr. Ramasamy, welcome. We're nice to have you here. What are the impacts of COVID-19 and the COVID-19 vaccines on male fertility and testosterone levels?
Absolutely. Thanks, Tony, and thanks, Dr. Peters, for the invitation. So the COVID-19 infection and the pandemic has certainly had an impact beyond just the lung. We all know it's a respiratory infection, but it certainly has extra pulmonary manifestations. I think the most common ones that we all can think of are brain fog, are people having their kidneys affected, but certainly the testes can be affected because the receptor to which the COVID-19 virus binds to is actually the mostly dense in the testes. And so the virus can actually enter the testis, can remain long inside the testis, long after the initial infection, and we have seen sperm parameters actually be affected. And in some patients, we've actually seen sperm counts almost plummet to zero. So at about 3 to 6 months after the COVID-19 infection, the sperm counts can go down. And if the sperm counts do go down, obviously the fertility rates can be affected as well. But reassuring news with the COVID vaccine, people often thought the COVID-19 virus and the vaccine would behave the same way. And unfortunately, lots of social media frenzy thought that vaccine would cause men to become sterile. And so we at the University of Miami did the study and published this in the journal JAMA. showing that the COVID-19 vaccine has no impacts on sperm parameters. So the virus is bad for sperm counts and for testosterone levels. The vaccine is not and is safe.
Dr. Ramasamy, thank you so much. Dr. Patricio, we're going back to you. Would you agree that an increasing number of women are seeking fertility care at advanced age, like 40 or older? And what are the options available to them?
Yes, I would definitely agree. We have seen this trend now for the last 15, 20 years, and particularly across the Western world. Women are waiting longer than ever to have their first child. In the United States, if you look at the 1980s, the age of first-time mother were 26 years old. And then 20 years later, this age now is 28 years and a half. Even in Canada, in the last 20 years, the age of first-time mothers is now 30 years old. So there is really across the Western society that the average age of women giving birth to their first child has been going up and up and up. Now, there are many social demographic factors that can help us to find an answer to that. But from a reproductive standpoint, it is really crucial and important that, yes, we do see a larger number of women that are coming to our clinics trying to have a baby at the age 40 or older, but it's important also to prevent this. And there are opportunities to prevent this. Besides the opportunity of offering fertility preservation technology that I mentioned before, like egg freezing, for example, but also education. You know, there is a profound misperception in that women think that they are fertile from the moment that they have a puberty until the moment that they have no more menstrual cycles. And unfortunately, the media has also contributed to this type of misinformation. When you look on the newsstand, that there are pictures of various actresses, Barrymore or Uma Thurman or other actresses, Monica Bellucci, the Italian one, that they all had babies in their late 40s. And they think, oh, well, if the actress did it, I think that I can do it too. The thing is that not all the information can be shared. And many of these women that are in their late 40s, close to 50s, they probably are not using their own eggs, but that cannot be said. So what can we do to preserve their fertility is egg freezing. So there is an important piece of information. So there is a biological clock. Let's be educated that after the age of 35, it becomes a little bit more difficult to get a pregnancy, which is really difficult after the age of 37, 38, when a woman approaches age 40. So if there is no partner in the horizon and a woman is now around age 35, probably there is a time to have a consultation with the reproductive endocrinologist and go over all the pros and the cons of entertaining the opportunity for egg freezing, because it's a remarkable technology. Today we know with many publication and research that we have also contributed to, we can safely say that egg freezing is a very viable technology, and the success rate in thawing or rewarming the eggs is really extremely high now. So it's not something that people need to be worried about. Oh my God, I'm going to have abnormal kids by freezing the eggs. No, that's not correct. So there is a technology available, and it's true that women older than 40 or older are coming to the fertility clinic. I just want to make one more comment on this, is that University of Miami, contrary to other practices, it's very much open to take care of these women that many times they are kind of rejected by other practices because they are so-called too old and they are driven towards the use of egg donation. That's not what we do. We want to really personalize, individualize the treatment and inform as much as possible the woman, because this is the patient and they need to make the informed decision on what they want to do. And it's not the doctor that has to decide for them. Thank you for the question. Very interesting.
Thank you. Dr. Ramasamy, I know you want to say something about this.
Yeah, so it's often thought that females have a biological clock and somehow men can keep making sperm the rest of their lives and they can keep reproducing for the rest of their lives. And it's often not true. So there's a small percentage of men where we've actually seen sperm decline with age. And the quality of the sperm can also decline with age. And I've always described this to men that come into the office who are in their 50s and 60s. and are now trying to have children. I think at about puberty, 12, 13 years old, the factory starts and the factory continues to make sperm and it makes sperm. But as men get older, there are old parts in the factory that just continue to make sperm, but they're defective. And it's not very good at repairing the sperm DNA that's made. So we've done studies here showing that the quality of the sperm DNA can actually decline with age. We're actually studying something called male reproductive aging now, and we still don't know exactly what factors can cause sperm counts to decline in some percentage of men, but it's certainly a phenomenon. I think we're going to talk a little bit about diet, environment, some of the diseases that men get during their lifetime that can cause to decline in sperm counts, but it's certainly a phenomenon. Not as pronounced as it is that Dr. Patricio described in females with starting to age 35 to 40, but certainly something that happens in men, because we're now seeing a lot of older men now coming back and wanting to have kids. So something that couples should recognize when they are thinking about having kids at an older age.
Thank you, Dr. Ramasamy. It's fascinating. And Dr. Patricio, thank you for being so candid about all of this. Dr. Delgado, we're back to you. How does endometriosis affect fertility?
Yeah, so since we're talking about the infertility here, so endometriosis, like I said before, the cysts are on your ovaries, and so cysts can also affect your ovarian reserve, essentially how many eggs you have and the quality of that. But also importantly, because the adhesions that endometriosis creates, it can cause the tubes to be blocked and scarring on the tubes. So it can definitely affect the ability for the embryo to implant, or for even like the sperm and the egg to be able to connect. And so women who have infertility, about 25 to 30% of those women will be diagnosed with endometriosis, or will have endometriosis, and about 30 to 50% of women with endometriosis have issues with fertility. So that is definitely something that we need to be mindful of when we're treating these patients, and how to schedule them and things like that.
Thank you, Dr. Delgado. Dr. Ramasamy, we're going to come to you. This was just sent to us. And I know men worry about testosterone as they get older, so it's an appropriate question. How do you see the impact of LNP on testosterone production?
Can someone describe what LNP is? I do not know what that stands for. I don't think that's a very commonly used abbreviation.
Do we have any answer for that? All right, well, how about we do this one then until we find that out?
Oh, sorry, it just, they described it. It's a lipid nanoparticle. Honestly, I've never heard of it. And I don't know if it's a therapeutic idea for increasing testosterone, but whatever it is, I'm sort of familiar with the literature that's been published on testosterone deficiency. And because it is so new, I'd be very cautious on patients that are trying to seek this therapy specifically to increase testosterone levels. We've done our own research here at the University of Miami showing Lytic stem cells can increase testosterone on its own in animal models, but we're pretty far from preclinical and proper clinical trials. But I'd just be cautious for whoever asked that question, especially now in Miami and major metropolitan cities. There are lots of quote men's health clinics that advertise increasing testosterone and offering easy solutions for men. So I'd be very cautious before proceeding with something that is not tried and tested.
Thank you, Dr. Ramasamy. Dr. Pedas, if I have had COVID, am I at a higher risk of having a miscarriage or having another pregnancy complication?
Well, Tony, thanks. That's a loaded question and a great one. So let me take a crack at this regarding COVID. So the way I would think about it is like this. So you have COVID when it's occurring in a pregnancy. And we all know about the effects of COVID. There's a lot of inflammation. And I think most people understand what inflammation is. And generally, it's not a good thing. And it occurs in a different variety of conditions. Like, for example, Dr. Delgado is talking about endometriosis. Lots of inflammation in that. In the COVID situation, we have a virus, and there are a number of things happening. One, the inflammation. Secondly, the viral effects. Now, when we look at what's happened with COVID in pregnancy, the data has been a bit mixed in that patients have had miscarriages. There's some data that suggests there's an increased risk. There's others that suggest not. And some of the other pregnancy complications as well, like hypertensive problems, like preeclampsia and preterm birth. And I would say from my look at all of this, the more severe the infection, the more likely it is that there's going to be a risk. But what we're also dealing with now that COVID is with us is we have long COVID. And about 30% of people that have had COVID have these longer related effects. And so then the question becomes, what happens when you've had COVID, you recover, you seem like you're back to normal, and what does that do? And so let me give you our experience a little bit. And I'll start with what's happened outside of pregnancy and this issue about inflammation. So what we've done, and we've been one of the only groups in the world that has actually looked at this, we had an opportunity to follow large groups of women unrelated to COVID, testing once they've had a positive pregnancy test and serially obtaining blood samples, about 5 during the course of the first trimester. And we were able to document in those unfortunate few cases that miscarried. What we found was very interesting, that the women that eventually miscarried had an alteration in the anti-inflammatory and pro-inflammatory ratios, such that the people that ended up miscarrying had more of a pro-inflammatory phenotype or pro-inflammatory tendency than those that eventually carried through in pregnancy. So taking that information and looking at COVID, what happened with COVID? Well, when COVID hit, we actually had to transform our entire laboratory because most of the other work had to get shut down for very good reasons. And we went hard to work at all of this. We invented a COVID therapeutic that we're now in testing, both for long COVID and hopefully for pregnancy and the adolescent up to age 18 age group. And what we're finding is that there's a lot of inflammation that's going on, and it's still persisting well out now, a year out into in the animal work that we've done. So when I think about what's COVID might be doing, I'm thinking that it's still simmering, and that there's still some pro-inflammatory effects that are occurring on, and it's occurring in various organs, the brain, the heart, the kidney. In fact, all the animals and all of the organs that we've studied so far, we see this effect. So my suggestion would be, if someone, to put this in the clinical perspective, if someone's had COVID, I would make sure that you're well over it clinically before attempting a pregnancy, like a couple 2 or 3 months or so. But it's definitely an area that is quite interesting to us. And this long COVID issue is going to be something that we're really going to have to understand. And we're beginning to do those studies here right now.
Thank you, Dr. Pados. Dr. Delgado, we just had this sent to us. Is there any new technology on fixing a blocked fallopian tube?
Great question. So in general, I'll start with endometriosis in general. So endometriosis treatment is surgery, so surgical excision. So when we are treating patients with endometriosis that are having issues with infertility, and I know Dr. Patrizio and I have spoken about this a little bit, we try to tailor the IVF and fertility options based on what's going on and what stage they are and what's happening. So as I said before, there are issues with blocked fallopian tubes during endometriosis and for other reasons. So for example, if you had a tubal ligation, so now there's some technologies where we can laparoscopically put the tubes back together. The data around that is still pretty sparse because
Dr. Delgado, we lost your microphone there. There you go. Let's give it a test real quick.
good.
Yeah, we're good.
Hello? Okay, sorry.
Circle back there.
Okay, so what was the last you heard?
Just restart that last thought you had will be perfect.
Okay, so when women have had a tubal ligation, which is something that can cause a block in the fallopian tube, there's new techniques for doing a laparoscopic excision of that scar and also putting that tube back together. But that also depends on many factors, and not many people are doing it across the country. So it's still pretty new technique. There are some other techniques that are minimally invasive that are mostly done by radiologists that they can put, it's like a small catheter that goes inside the uterus and it goes through the tube to help unblock it. But again, there's not many centers that are doing this work. And I know Dr. Patricio, you might have some more input on this as well, but I know a lot of the times with doing more surgery, for example, cutting the tube open if there's fluid inside, that causes even more scar tissue and can cause more issues like an ectopic pregnancy in the future. It puts you at higher risk.
Great. Dr. Delgado, thank you.
I can also add, Tony, about
Yes.
this very important question about how can we fix the tube, or is there anything new on the horizon? The problem with fixing a tube that is not blocked by tubal ligation or is not blocked by scar tissue that can be excised during a laparoscopy, let's say there was a kink in the tube, but if the problem lies in fallopian tube, so in other words, there are so many specialized cells that are lining the inner part of the fallopian tube, and in those cells, they have little fingers that they are in charge of moving the eggs and the sperm to meet at the right point in the fallopian tube for their union. And then they need to move the embryo, the fertilized eggs, down into the uterus 5 days later. So the problem is that if imagine that like a room with the wallpaper that has been all tear apart and is all not functional. If the tube is completely damaged, blocked, there is no way that I can put a new carpet in there. So therefore, at the moment, there is no device, no plastic operation that can be done to repair those extensive damage. And the best thing to do is to do in vitro fertilization, that you completely bypass the fallopian tube. Because even if you try to do something, fixing it and opening, then you need to put in account also the risk for ectopic pregnancy, which means that a pregnancy that implanted into an abnormal fallopian tube that can also be dangerous. Okay.
Thank you, Dr. Patricio. Dr. Ramasamy, we're going to come back to you because this was just submitted. They want to know what can be done for sperm motility.
So there are many reasons why sperm motility can be low. There can be some of the most common conditions we see are something called as a varicocele, which are dilated veins that are around the testis that can increase the temperature of the testis and affect both the sperm production as well as the sperm from moving. Some of the other common reasons are that the testes make a lot of sperm, but then in conditions such as patients who are smoking either cigarette or marijuana, exposures at work, either secondhand exposures, some of the commonly used drugs can also affect sperm motility. Sometimes supplements can help improve sperm motility. Sometimes medical therapy is required to improve sperm motility. And sometimes surgical repair of the varicocele is required to improve sperm motility. So really depends on what the underlying cause is and what we can try and do to fix the sperm to help it move faster.
Thank you, Dr. Ramasamy. What a fascinating evening so far, ladies and gentlemen. This has been amazing. Dr. Patricio, you're up again. Is there emerging research in the field that can give hope to women with unexplained infertility?
Nice question. Unexplained infertility should be read more as our inability to understand what's wrong, because it's unexplained because we cannot find the reason, but there is a reason. We still cannot find it. And the research is directed at in 2-3 directions. One is trying to unravel more and more possible genetic conditions that can be impacting either egg quality production or sperm quality production, or subtle changes in the sperm functionality or the egg functionality. Sometimes we think, and we are believed to think, that once a sperm and an egg got together, the job is done. But no, that's probably only the beginning. And therefore, we are now starting to understand that there are steps at which fertilization can go awry, even though there is an entry of a sperm into an egg. So genetic studies, in addition to genetic studies, it's also important to realize that if a couple is being diagnosed with unexplained infertility, which is about 15%, 12% of couples, we really cannot find a reason why things are not happening. what is important to realize is that sometimes colleagues, they say, okay, unexplained infertility, you've been trying for 3 years, I cannot find anything wrong, you're ovulating, your fallopian tubes are good, the sperm count is good, motility is great, morphology is good, everything is good, I really don't know what's going on. Maybe you had dorsal laparoscopy, there is no endometriosis, there's nothing hiding. Let's do insemination. Well, insemination is when we put sperm inside the uterus with the hope that that will be helpful, but helped very, very little. In those cases, anecdotally, but not so much anecdotally anymore, because we are doing a follow-up on some couples, we see that there is an issue with the eggs, for example, that there was no other way to uncover it until you do in vitro fertilization. So the egg is completely full of vacuoles, some little abnormality ultrastructurally that you don't know, you cannot understand if you don't do the in vitro fertilization. So we are shaving off cases of unexplained infertility by really applying the power of genetics, the power of in vitro fertilization, studying how the embryos progress. And there is also another little subtle things that probably Dr. Delgado can also comment, is that for a long time, we were kind of disregarding the presence of a minimal endometriosis within the context of the uterus that is called adenomyosis. But now there is more emerging research saying that the presence of endometriosis in the context of the uterine wall, called adenomyosis, may also play an important role for the embryo to implant. And therefore, imaging studies, genetic studies, in vitro fertilization studies are really shaving off this big rock of unexplained, and we try to understand really what's wrong in some couples. And finally, I want to conclude by saying that many times has happened for people that are around in the field for so long, that when you just throw the towel and say, no, I really don't know how to help you, then they go home and then they call saying that now I'm pregnant, and I did all the testing, everything, and now I'm pregnant. So there is also a quote in the Bible that Rachel was not able to get pregnant for a long time until someone gave some seeds of mandragora seeds. I'm not saying that we should do that, but only once she was completely relaxed, then she went on and got pregnant many times.
Thank
I
you.
wanted to just,
You're always yes, Dr. Pettis. Would you like to weigh in on that, on the scripture or on the answer?
we have such an august group here. We're getting a lot of press about the microbiome, and all our department is really steeped in looking at all of this. And I wonder, with all of you here, what do you think about the microbiome and how that's playing a role in infertility? I know we're beginning to look at it, but what's your thought about it? Because that seems to be something that we could potentially manipulate. And we've had a lot of these cases, we've shared many patients together where, there's been this long infertility, and then all of a sudden, out of nowhere, someone like you were mentioning, Pasquale, they become pregnant and it happens. So have we done enough to look at the microbiome?
Well, there is currently a study that we are doing in our division about looking at the microbiome of the uterus and the cervix just at the time that we are doing embryo transfer. And this is with the quorum sensing technology, which is a technology just really to understand what type of microbes, what type of microorganisms are present more or less in women that they get pregnant versus those that do not get pregnant. So certainly this will be shedding lights. The microbiome is probably a very important component of not only our particularly hygiene, diets, activity, stress levels. And I personally think that is going to be playing an important role. And I'm sure that Dr. Ramasamy is probably going to say something also for the microbiome for the male genital tract.
No, so I mean, unexplained infertility, I think, genetics you spoke about, Pasquale, I think microbiome and alterations of microbiome could play a certain role. I've always told couples, reproduction is a miracle. I think what we know in reproduction and fertility is just the tip of the iceberg. There's so much that we don't know. And I think the more and more we uncover genetics, more and more we uncover things like microbiome, I think the more and more couples are going to have some sort of quote closure on why their infertility is happening. And hopefully we can alter some of those factors to try and get some of these couples pregnant naturally.
Thank you, Dr. Ramasamy. Dr. Delgado, we have a question for you, but I'm assuming you'd like to answer this too, please.
No, I just wanted to make a comment back to what Dr. Patricio said in terms of the unexplained infertility and adenomyosis, which is the endometriosis in the wall of the uterus. The big issue with that as well is that the only way of really diagnosing it is doing a hysterectomy and cutting into the uterus and looking at it under a microscope. And so that makes the even imaging, like MRI is the best for diagnosing it, but even imaging is not perfect and it doesn't pick it up all the time. And so I also wonder if what we were talking about before in inflammatory markers in endometriosis, if we could test those around the time of IVF and testing those markers to see if maybe that correlates with adenomyosis as well would be interesting to look at unexplained infertility.
Thank you, Dr. Delgado. We have a question for you that just came in. I have polycystic ovaries. How does it affect fertility?
Great question. And polycystic ovaries is we see very commonly in our clinics. Polycystic ovarian syndrome, what it does is it causes you not to ovulate regularly. And so because of this imbalance of not being able to ovulate and not having a menses every month, that's the main trigger for why you're having trouble getting pregnant and having a little bit more issues. That being said, not every person that has PCOS has trouble getting pregnant, but a lot of our patients that I've seen, and Dr. Patricio, I'm sure you can comment here as well. A lot of patients with PCOS do struggle because trying to get you in a normal cycle, the only way of doing that is putting you on birth control pills, and that obviously doesn't work to get you pregnant. So it's a challenging thing to manage. But there are medications that we can give to help induce ovulation and help patients get pregnant with PCOS.
Dr. Patricio,
is a disease that it's characterized, like Dr. Delgado correctly said, by this hormonal imbalance. But there are but 3 forms of this condition. Okay, for a long time we just focused on the fact that okay, there is an elevated level of androgens, male hormones, in women, and there is this kind of a paradox that we have ovaries that are fully endowed with eggs, but these eggs cannot be released because of this hormonal milieu that keeps them very small. And when you have a very small follicle or eggshell, they form all these so-called cysts. So poly means many cysts, but so it's a kind of a sad thing that there are so many eggs, but they are not going to grow towards ovulation. Now, there are medications, yes. There are also conditions where maybe there is so much androgen production that there are some other symptoms. There are some other events that need attention. Yes, for example, excess hair, obesity, and the fact that there is a glucose or sugar dysfunction, metabolism is altered, so insulin and glucose need to be controlled. So now it's not only the reproductive entity that has to be taken care of during the polycystic ovary, but it's also important, we call the so-called metabolic syndrome. So patients can have a tendency to diabetes, hypertension. So that's why it's also important the collaboration when they try to get pregnant with the colleagues in maternal-fetal medicine, Dr. Paides and the colleagues, because they need to make sure that that patient is really in a good balance before we plan for a pregnancy. But unfortunately, is a condition that it's more common in particular groups. Hispanics, for example, they are very much more frequent, and most likely there is a genetic component, a polygenetic component that we have still yet to figure out in details.
Thank you, Dr. Patricio. Dr. Paides, this was just sent in for you. If you have gone through IVF and miscarry with twins at the age of 21 weeks, what are some factors that can cause the miscarry, and what can you do differently in the future to prevent another loss?
Oh, my heart goes out to the person who wrote that comment. So here, what we're talking about, we have to distinguish perhaps between preterm birth, so a live pregnancy, babies that are fetuses that are alive, but then are miscarried because of the prematurity, or are we talking about babies that have succumbed? So you have a fetal demise, sort of two different items. In the case of the early preterm birth, overwhelmingly, the multiple gestation is typically the biggest factor in causing that early delivery. So the more fetuses that are inside the womb, the earlier that will deliver. And so having a singleton, and that's why there's such a big push to having single embryo transfer to limit multiple gestation. Now, sometimes when you put one egg inside, it will split and you will end up with twins, and rarely beyond that. So one is really concentrating. If you have to go through IVF to achieve a pregnancy, my recommendation would be single embryo transfer. And then we would do other things. We would make sure that the uterine cavity is normal. Is there a septum? Are there other issues going on? And then we would give progesterone to help reduce the risk of preterm birth. And in select cases, I also actually close the cervix if needed early on in pregnancy, called the cerclage. And that's done typically vaginally. And there are a couple of ways that we do that. And then there's also, in some cases, abdominal, in certain cases where we do it with an open abdomen or laparoscopically or robotically. And then on the other hand, if you're dealing with a pregnancy loss, as in a fetal demise, that's a different sort of complication. And there's a diagnostic workup for that as well. There's a genetic piece to it. There's some clotting related factors that need to be looked at. And then we think about, all right, have we ruled out everything? And then there are some ways that we can tailor therapies and preventive strategies, which involve, in some cases, anticoagulation, aspirin, progesterone support as well. There's a growing amount of literature now, pretty solid evidence that these higher doses of progesterone vaginally, 400 milligrams twice daily until 16 weeks, really reduces the risk of miscarriage, unexplained miscarriage. So those would be my thoughts.
So let me ask you this, Dr. Pados. Is it necessary to receive a hysterectomy after a miscarriage to determine the cause of the miscarry? This was just sent in to us in the middle of your answer before.
Yeah, so not hysterectomy. And I think what you're talking about is examining the products of conception, and that can be done with the DNC, and aspiration or collection. Sometimes patients will go and spontaneously miscarry, or patients that we think are at risk or on the verge of miscarrying, we'll tell them, please collect the tissue, we'll give them a container, etc. Now, what we can do now, the genetic diagnoses really are available to us, are really pretty wide right now. So we can actually take those tissues and then have them analyzed. That's really terrific. So we can get genetic diagnoses often on the miscarriage tissue. But another thing that we can do is actually have a placental pathologist examine the tissue. So it's not giving us a genetic diagnosis, but it's looking at the tissue and saying, do we have overwhelming evidence of inflammation, of altered immunity, of thrombosis, or infection? Or does it look like there's a metabolic syndrome or some other genetic variation? So we can learn a lot about the pregnancy by examining, the contents of the placenta and the fetus.
Dr. Pados, thank you. Dr. Ramasamy, you touched on this earlier and said we would be discussing it later in the hour, and we are now. What are the impacts of environmental factors on male fertility and testosterone levels?
Absolutely. So a lot of diet and environment apparently seems to affect both sperm counts, sperm DNA, as well as sperm motility. I think we talked about it a little earlier, but certainly smoking, weight gain, obesity, metabolic syndrome, all of that can impact both decreased testosterone levels and decreased sperm counts. In fact, a very beautiful study was done in the diabetes population, where they treated men with both weight loss, a drug, and as well as men who underwent weight loss, and they found that the sperm counts almost doubled. It's one of the first few studies that basically showed that losing weight will actually improve both sperm count and as well as quality. And now in modern day technology, we're now exposed to so many things that may or may not impact, just don't have definite conclusions, such as radiation, cell phone radiation, heat, hot tubs, saunas. All of them can all potentially impact both sperm counts. But I think things that I often tell people are things that are good for your heart are also good for your sperm. So anybody that ever says, "Doc, what can I do to improve my own sperm counts and quality?" Eat well, exercise, sleep well, try to minimize stress. And clearly, if you have any offending variables like smoking, alcohol, drugs, please stop it, because all of that will help improve sperm counts.
Thank you, Dr. Ramasamy. Dr. Delgado, for someone with a history of endometriosis who is having issues with getting pregnant, what are the options?
Yes, thank you. So when someone who has a history of endometriosis and is trying to conceive and is undergoing assisted reproduction, we typically, and everyone is different, and we tailor our therapies based on the patient, each patient. But the idea is that the hormones that we give to do an egg retrieval can actually stimulate the endometriosis. So it can stimulate more endometriosis to grow, or it can worsen the patient's pelvic pain and symptoms. And so what I recommend as on the surgery side is doing the egg retrieval first, doing I usually do a robotic excision of endometriosis, because after doing it after the retrieval, we can possibly remove more endometriosis that was maybe a little bit more dormant that we wouldn't have been able to see. And then after that, after recovery from that surgery, is actually the best time for fertility, and so best time for the embryo transfer. That being said, if you have a very large ovarian cyst, a very large endometrioma that's pushing on the rest of your follicles on your ovary, in that instance, I would recommend removing the cyst first and then proceeding with the egg retrieval. So it's very much tailored to what each patient. But I would say overall, the idea is to do a retrieval after getting higher doses of hormones.
Thank you, Dr. Delgado. We're going to circle back to the pregnancy loss, to the miscarriages, and this is for Dr. Patricio and Dr. Perez, for both of you. And the question goes like this: is there any new research being done to provide options for patients with recurrent pregnancy loss? Dr. Perez, do you want to start us off on this one?
Yeah, sure. So I would look at this in a couple of different lights. One is on the diagnostic side, and I'll let Dr. Patricio elaborate if he's would like to. And that we now have this capability of really looking at essentially so many of the genetic variants and abnormalities. So that's one big piece. On the diagnostic side, we're also looking more and more, and my own interest for the past 20 years has been looking where the rubber meets the road, essentially, where the pregnancy is meeting the uterus and that uterine lining and the cells that are right underneath that. And out of that work actually is where we've uncovered therapeutics, which we are now looking at in a variety of pregnant and non-pregnant conditions. But where we are exactly right now is in unexplained pregnancy loss, where we've done a complete evaluation. We can't find anything. The one thing that we would offer is the progesterone support, and that does seem to help. That's one. If we find antiphospholipid antibody syndrome, we have a treatment for that, and that seems to be worked very well in those select patients that have it. As I mentioned, I'm particularly interested in looking at the immune causes and the regulation, where the mom and that placenta, the fetus, that interaction and what's happening there. And we are really focused on teasing that out and understanding what are the mechanisms regulating all of that. Very much like when you think about pregnancy, a mom accepts the pregnancy, their immune system is altered. It's not depressed, it's just modified. And what we're trying to do is harness that information to develop therapeutics that will to help the pregnancy and maintain pregnancy, to limit the sort of the hostile interactions that sometimes can occur, the pro-inflammation or the immunologic challenges that occur. So that's kind of where we're at right now, and we're looking really focused on that early implantation events. So Pasquale, I'll hand it over to you.
Thank you, Michael. I totally subscribe to the way that you have put it together, and I just want to tell the audience that we really need to understand when we call unexplained recurrent pregnancy loss. Again, the word unexplained means that we are not able to understand yet what is causing that. And in particular, those initial early stage of implantation, where the embryo is finally attached to the endometrium, to the uterus, and starting to establish those vascular connection, and there is a huge immunological, antibodies mediated series of steps that are going on. And we need to really decipher, understand what are all these steps. And therefore, what Dr. Paida said, the immunological component, the inflammatory component is important. Is the microbiome also involved? Most likely. Is the genetic, not chromosome, genetic meaning is any function of genes that are involved in those initial steps and may be faulty, and we still don't know how to identify those genes. Can also be that the culprit? Yes, it can. Because we have seen, and I published this a couple of years ago, that, for example, when a pregnancy is lost constantly in the first 2 weeks after pregnancy established, 6 weeks, pregnancy loss, 6 weeks, pregnancy loss. And some even earlier, 5 weeks, we call it the biochemical pregnancy loss, meaning that there is a positive pregnancy test, but there is not yet a visualization of a sac that is implanted. Okay, so we thought that by doing genetic chromosomal testing on the embryos, so checking the embryos before we transfer them during in vitro fertilization, was going to resolve those issues. It did not. So there is really no difference, no impact whatsoever in decreasing early pregnancy loss, even if we check the embryos with the chromosome testing. So something else is going on, and that's why, like Dr. Paida said, we need to go in the direction of genes that may be involved in the early implantation that will establish a very nice, solid placental perfusion, and immune cells are really critical in this initial step. So we are studying that, and pretty soon with some markers that Dr. Paida also saying that we are now closely looking at, we may be able to come up with, again, carving out some of this unexplained in the recurrent pregnancy loss diagnostics.
Thank you, Dr. Patricio. Dr. Ramasamy, would you like to weigh in on this?
So men can contribute to recurrent pregnancy loss. I think we've talked about sperm DNA quality being fragmented can also impact pregnancy loss. So anytime couples come to us on the male side with pregnancy loss, we make sure we check a karyotype, because sometimes chromosomal abnormalities on the male side can be contributing to abnormal chromosomes in the growing fetus. And the same thing, we also check a sperm DNA test. If the sperm DNA test is elevated, we talk to couples, and especially the male partner, about strategies in which we can try and improve the sperm DNA quality. So if they're going to try again, either naturally or undergo IVF, they'll have a better outcome this time around.
And Dr. Delgado, we can't let you go without asking you if you'd like to comment on this as well. We have to add you in here. This is an open panel here. We've learned so much tonight. We've learned scripture. We've learned from Dr. Patricio about on covers of magazines. We may as well learn something from you.
Yes, I mean, I think going along the lines of the inflammation route and how, from an endometriosis standpoint, I can see that could be related to recurrent pregnancy loss. I think I agree with everyone. I think we need more studies and we need more research, especially more of like the basic science, looking at getting down to the basics of it, to look at how inflammation in endometriosis and adenomyosis is affecting recurrent pregnancy loss. That data is not very robust at this point.
Thank you, Dr. Delgado. Before, ladies and gentlemen who are with us, before the hour started, we had all the doctors on and we told them that the hour flies by. Doctors, do you agree that the hour flew by?
Very much so.
Yes.
It was fantastic. We'd like to thank all of our panelists, by the way, who helped us explore this topic. It's so important and it's so vital, and there's so much talk about it. And you've heard from all of our doctors that there's so much stuff in the media that's misleading in many ways. So that's why it's important to come to the source. And at the University of Miami and the Miller School in particular, with doctors like this, you find out the truth, and it's amazing work that they're doing. Dr. Paitis, how about setting us off tonight and give us some final comments before we close the evening?
Well, thank you, Tony. And many thanks to all of our viewers. Your attendance and your questions are vitally important to us. And what you've heard tonight reflects the innovation, the passion, and commitment that are at the core of our mission here at the Miller School. Our team of experts are committed to delivering timely and appropriate treatment options for every patient that will lead to the most promising outcomes. We also hope that we've given you the information necessary to know when to seek treatment. And your generosity ensures we continue to conduct pioneering research, deliver the very best treatment, and support our outstanding physician scientists in the field of fertility. So many thanks, and I wish you all a good evening.
Dr. Paitis, Dr. Delgado, Dr. Patricio, and Dr. Ramasamy, what an amazing evening, and what a way to kick off another year of our In the Know series. It serves as a stunning reminder how truly fortunate and blessed we are to have doctors like we heard tonight, right here in our backyard at the Miller School. Doctors who not only are brilliant and talented, but filled with passion for what they do. That right there is pretty special. And one more thing, we had more questions tonight than we could have ever handled. We still have a number of them we didn't get to tonight. We promise you, we will get you answers to those questions in an email, and you will get all these answers tonight. It was so important, and so we are so thankful for all of your participation in tonight's In the Know. And please remember that a full recording of this, if you want to see it all over again, you can learn more. You can even get that other thing from scripture from Dr. Patricio about Rachel and what she took before pregnancy. Please remember that a full recording of this program will be posted online. Look for the link in the coming days. And in a moment, you're going to see a survey about tonight's town hall on your screen. Trust me, it takes about 20 seconds to fill out. It's real simple. Take the time to do that, because we want your feedback. Here's why. It helps us understand your interests and improves our program. As always, we wish you and your family good health. Doctors, again, you were fantastic tonight. And for all of you joining us, remember, it's always about the you. Good night, everyone.